So now next I invite Dr. D. Ramamurthy for his talk on continuous range of vision technology. Life begins at 33 centimeters. Over to you, sir.
Thank you. This is intervening in between some talks on phakic intraocular lenses, and this is a sponsored talk, and I'm a consultant for J&J and Alcon. And the continuous range of vision intraocular lenses is an interesting addition to what the armamentarium that we have. And today I find that whenever I prescribe glasses, whether it's to a 10-year-old or a 40-year-old getting his first pair of presbyopic glasses, or a 62-year-old who has got a cataract with a PMMA lens done, there is a tinge of disappointment. I thought, why me? Do I really need these glasses? So obviously the way to go, if you can address this and give them glass-free, spectacle-free vision at whatever age they present to us, that will be a great way to go. We have been doing multifocal intraocular lenses for a couple of decades now, but still the adoption, slowly the numbers are rising of late, but it's less than 20% in my own hands. The reasons is not just the cost alone, but the fact that we are unable to promise them continuous range of vision for near, intermediate, and distance. That's what most of our patients demand. Again, the challenge is also that they want to see at odd lighting conditions, bright light, dim light, night vision conditions, etc. And obviously, the dysphotopsia is a problem which most of the multifocals, trifocals, even the EDOF lenses come with. And that's the reason that the uptake of these lenses still remains somewhat less than what we would desire. As we all know, the first lenses that we are comfortable with, the monofocal intraocular lenses, it's a no-fuss lens where you find that, okay, the pointer is not showing, where you can see that there's an excellent focus. The focus is where the gray area is. Excellent focus as far as the distance is concerned. Intermediate and near, obviously, you require glasses. Then came the bifocal, the diffractive bifocal lenses, and there was good focus for distance, good for near. The initial lenses I used were the Technis 4-diopter lenses, add-on lenses, excellent near vision that they used to give. And obviously that was, but there was a significant area where the vision was not quite adequate. And then the trifocal lenses, that you can see by the whitish area in between. And then the trifocal intraocular lenses where you had the distance vision, the intermediate vision, and the near vision. But then as far as the intermediate vision, you had to choose between 60 centimeters and 80 centimeters depending upon the optics of that particular lens. Again, there were some areas where the vision was not continuous. So the continuous range of vision lens or the synergy, what it attempts to give you is a seamless visual vision across all distances from distance, near and intermediate. And at least in my hands, I see that bilaterally implanted, most of these patients function quite well from 33 centimeters to almost till infinity. Why is it called synergy? Because it's a combination of two technologies. The first lens, as I mentioned, the multifocal lenses I was used to was the Technis Plus 4, then the 3.25, then the 2.5, and of course the Alcon platform lenses also. Excellent distance and near vision, but the near vision used to be at 25 centimeters, 33 centimeters, etc., depending on the add power of that lens. But then the dysphotopsia was somewhat unacceptable in dim light conditions, as well as there was a central area, the intermediate zone, the vision was not adequate. EDOF lenses came with was a compromise solution where the quality of vision was somewhat better, but then for near vision you definitely needed glasses. So the synergy is essentially supposed to combine the virtues of both these technologies. And as you can see here, what you see over here is that green line, what is shown in the green line is the ideal, where we want an excellent visual acuity for distance, and all the way from intermediate to near, you want the vision to be somewhere in 20/30 or better. But obviously, when you go on to the what's represented by the gray line, the EDOF lenses, what you find is that there is a good vision for distance, and there is a reasonably good vision, 6/6 or 6/7.5 vision as far as the intermediate vision is concerned. But beyond 1.5 diopters of defocus, there's a steep fall, and that's the reason that you need readers. When you come to bifocal intraocular lenses, that's by the deep curve over here. There's excellent vision for distance, good vision for near, but then there's a central trough where in the intermediate area, the vision is not so good. So what you have in this second curve is what's for the synergy, which is represented by the blue line, which almost mimics the ideal, where there is a peak for the distance and a fairly good 20/30 vision maintained for near as well as intermediate. Of course, this is if you hit emmetropia and you have the choice of doing something to the other eye, so the second eye, so that bilaterally implanted these lenses work quite well. It's essentially, when I was initially introduced to the concept of HL8 with the EDOF lenses, I thought this is unique to these lenses, but almost the monofocal lenses also have a HL8 pattern. And it's a proprietary diffractive design of the synergy, which is optimized to deliver a full range of vision with a peak at distance and continuously distributed from distance to near, which enables these lenses to function quite well for all distances. And this is, it's the type of HLA that's incorporated in the EDOF lenses, in the trifocal lenses, in the CRV lenses, that determines the actual power or the actual defocus curve of these lenses. Then again, the one thing which always used to bother us is the contrast loss. And whenever you split light, which all these multifocals or trifocal lenses do, there is a compromise as far as contrast is concerned. And as you can see over here, the MTF values at 3 millimeter pupil for all the normally used lenses, whether it's a synergy or the trifocal lenses, is almost similar. There's the synergy scores a little better. When it comes to mesopic conditions, when the pupil dilates to 5 millimeters, as you can see, the MTF is almost twice as good as what you find with the commonly used trifocals. There are reasons for that, and I'll shortly allude to it. And this is a very important optical quality slide. You might do well to understand this. And as you can see, even with the normal monofocal intraocular lenses, even with the normal optics of the eye, the MTF, or what is MTF, the modulation transfer function, is nothing but the ratio of the contrast between the object of regard and the image it produces. What is the drop in contrast that occurs when a ray of light passes through an optical system? And as you can see, even with the monofocal intraocular lenses, there is a drop in the MTF values. With the multifocal intraocular lenses, the drop is significantly more. And what is shown in the darker areas over there is when the pupils are mesopic, when the pupils are mid-dilated, and you can see the MTF drop is significant in these cases. With the trifocal lenses, both the MTF, both for in the photopic and mesopic conditions, is almost half as much as of what you get in the monofocals. That's the reason that you have a significant drop in quality. But when you look at the EDOF lens, the symphony or the synergy, you can see that that drop in quality of vision that occurs from photopic to mesopic conditions is significantly less. And also, you can see that 0.40 here, the 0.40 here, and again, in the mesopic conditions, it almost matches the quality of vision that you get with monofocal intraocular lenses, and that's a significant advantage. And then you have the chroma line technology incorporated in this. What exactly in that? We have used to spherical aberration compensation for quite some time, where we have a minus 0.27 Q value on the lens, which compensates for the average positive Q value in the average cornea. Chromatic aberration, again, all normal eyes have a positive chromatic aberration. And when you put in a conventional spherical lens, that also comes in with a spherical, with a positive chromatic aberration. And because of which the amount of chromatic aberration that the patient has to deal with significantly increases almost up to 2 diopters. That is, when green light is in focus on the fovea, the blue light gets focused in front and the red light behind the retina. So obviously this also causes a deterioration of vision. But the chroma line technology which is incorporated in the symphony as well as the synergy has essentially a negative chromatic aberration, and this to some extent compensates the positive chromatic aberration of the normal human eye, because of which the total amount of chromatic aberration apart from the spherical aberration is also reduced. And this is the slide showing you the chromatic aberration. As you can see over here, both for the Technis Symphony, the dotted line actually represents the chromatic aberration of the aphakic eye. And when you implant some of the more common lenses, the multifocals as well as the trifocal lenses, essentially they increase the amount of chromatic aberration that is there in the eye. But with the Technis Symphony and the Technis Synergy, because they have negative chromatic aberration, you find that the chromatic aberration subsequent to the implantation of these lenses is reduced. So we all know this. These Technis platform of lenses have a minus 0.27 Q value on their lenses, and because of the reduction in the chromatic aberration as well as spherical aberration, there is a synergistic effect. It's just not a simple add-on, and because of this, our quality of vision is significantly better with these lenses, and that is something that we have experienced. And you can see this lens. The another important factor that's incorporated in this is that it has this specific blocking of the blue light, while it allows the violet light. It blocks the violet light, while it allows the blue light to pass through. When you talk about the conventional blue blockers, they block up to 480 microns. 400 to 440 is violet, 440 to 480 is blue light. The violet light, which has the lower wavelength, causes much of the scatter, deterioration in the quality of vision. But the blue light is something which is good for mesopic vision, which is good for the quality of vision, has a role in circadian rhythm also. So by blocking the violet light, by allowing the blue light to pass through, the good light is allowed to take part in the visual phenomenon, while the scatter by the violet light is something that's reduced. This is just a very short video, and it's the implantation, the orientation of these lenses is very much like what we have with the conventional Technis lenses. It's a 6 millimeter, 13 overall optics, 13.5 millimeter overall single piece hydrophobic acrylic implant, glistenings free, and it has to be implanted in the back. It has full diffractive rings right through, and because of which, even in mesopic conditions, the quality of vision is reasonably good. And that's just the implant which is being finished. And basically, the Synergy is supposed to give you a continuous range of vision from 33 centimeters to distance. It corrects spherical aberration as well as chromatic aberration, which contributes to the quality of vision. And because it's a 6 millimeter full optic lens, it's a pupil independent lens, and it blocks the ultraviolet and the violet light while letting the blue light pass through. And you have the toric platform also integrated in this, so that you can take care of the cylinders. And it comes in the tried and tested Technis platform, which we are used to for more than the last couple of decades. So basically today, even the elderly want to live their life to the fullest, and I think these kind of lenses, it's not that I use only the Synergy lenses, but I'm a big fan of the multifocals as well as the toric lenses. And it's good to have choices, and we choose the right patient and the right lens and match them together. The results are quite amazing. Thank you so much.
Thank you, sir, for such an excellent talk. I think we are moving from now this trifocal to CRV, because in the trifocal we are having a split. We are having 3 focus. Because of that, we are losing the contrast, because when you have 3 focus, there is that losing of the contrast, because you are losing the light, because I think 80 to 86%, and in the CRV we have continuous, so we are not losing the amount of light in the CRV technology.
Still,
we have some
88% light is
88.
utilized, 12% here
CRV
also. So it's not as if Synergy is without dysphotopsia.
Okay.
It does come, but then it's supposed to,
little
because of the chromaline technology, and as you said, better light utilization, the 82% what's utilized there, the amount of dysphotopsia is slightly less.
Okay, sir. Dr. Mal.
So what is your choice of patient? Because I think that's very important. So which patient would you prefer to use, say a trifocal or a monofocal or EDOF lens or the Synergy? So, how do you categorize them based on their functional and their vision needs?
So supposing it's a patient who doesn't read, doesn't require much of reading vision, is quite happy with the monofocal. Cost is also constrained, and definitely we go ahead with a monofocal intraocular lens. It's a no fuss lens. But in case the patient is concerned about wants to read and wants to do everything without the need for glasses, then trifocals or the continuous range of vision lenses is the way to go. We use both the Synergy as well as the Panoptics, and quite a few Indian trifocals also in good numbers. And we find that as far as the choice of patients, the counseling is right, the results are quite satisfactory. But if the patient is somebody who says he's in his 60s or 50s, but says every day I have to drive back home for 8 kilometers, and that's it. Driving vision is extremely important because you are never able to predict who are the patients who are going to have this dysphotopsia. Then we would counsel these patients, and some of them still choose to go ahead. They say that I'll manage, let me see if it works for me, and surprisingly, many of them do well. Unfortunately, for all of us, we only remember that occasional patient who takes a lot of chat time and complains, but there are many of them getting routine surgery done and going away quite happy. And as far as you take care of the cylinders also appropriately, then the results are quite good. The EDOF lenses, I feel that whether it's the monofocal plus lenses, the EDOF lenses, is a compromise both as far as the quality of vision and the quantity of vision is concerned. We always tell them that you would need readers, and in case you have talked to them about they are interested in multifocality but then get put off by dysphotopsia, you say, okay, this is a compromise solution, go ahead with this monofocal plus. I think you have the iHands, you have the Everlex and other lenses. These are okay, they give about a 0.5 to 1 diopter as far as intermediate vision is concerned, but for reading you require 1.5.
And so do you have, what is your experience with mixing and matching lenses?
Actually, I used to do it all the time. Usually was allowing 2 weeks gap between the two eyes. It was not just the shift in the spherical power of the lens, but also even the type of lens implanted. We have quite a few patients who received Symphony when it was very much in practice, and now when they are coming for the second eye, we are putting in a trifocal because that was not quite adequate for, and it works. I mean, there's nothing this lens doesn't work with the other lens. But what I find with the CRV lenses as well as the Panoptix lenses, if you hit emmetropia, the need for mixing and matching has significantly come down. It used to be much more in demand when you had only the bifocal lenses with a +4 or a +2.5 or when you had the EDOF lenses like the Symphony. But with the Panoptix, the Indian triphobic, the Synergy, I think the need for that has come down.
Yeah, right. Thank you.
Thank you.
Sir, can we put one eye monofocal and other eye trifocal?
Yeah, I mean, we do come across these patients, where the one eye has already been operated years back. You might yourself done the surgery, and now because their friends and relatives are having this, they come. You tell them this is not ideal, but then I have implanted quite a few, and these patients are able to function reasonably well.